UW School of Veterinary Medicine, and I hope all of you are having a great evening. Tonight we're going to be talking about how the school helps pet fight cancer, and our two presenters tonight are Lisa Forrest, which I think should be clear is not me, and David Vale. I'm Mark Markell, Dean of the School of Veterinary Medicine, and I think we have a mild technological glitch with Lisa right now, so we're going to have David lead off, but I'll get to that in a moment. So let's move on to the next slide, please. So the last year, as all of us know, has been amazing, might be the best way to phrase it, or catastrophic is another way, but it certainly started out amazingly with David McNeil, founder and CEO of WeatherTech, who decided to honor his Golden Retriever Scout and the School of Veterinary Medicine in WeatherTech's 2020 Super Bowl ad. And Scout's story not only shared Scout's treatment here at the school, but also importantly highlighted really around the world all that veterinary medicine does to advance both animal cancer treatment as well as human cancer treatment. And I think it was incredibly impactful to who we are in the veterinary medical profession, as well as who we are at the UW School of Veterinary Medicine. And Scout's legacy continues today in how we diagnose, treat, and prevent cancer. And importantly, I want to just acknowledge that, you know, I've been at the School of Veterinary Medicine for 30 years. David and Lisa have been there for multiple decades as well. And really, it's been the support of friends of the school like you, whether it was this past year through WeatherTech's and David's highlighting of our program, or whether it was 10 or 15 or 20 years ago when you learned about us, probably through the treatment of one of your animals in their cancer path. Next slide. The gifts to our oncology program, not only this past year, but in previous years, have allowed us to hire an additional clinical trials intern. You're going to hear much more about that from David as we move on, David Vale. We've also been able to initiate many more oncology clinical trials. And as you'll hear from Lisa, hopefully, we were able to purchase a new radiotherapy delivery system, which I'm not going to steal the thunder on, but you'll get a chance to see that in a moment. As you all know, our world has greatly changed in the last 12 months, certainly the last 10. We were one of the first units on campus that had a positive COVID patient on March 13, actually. So 10 months and a couple of weeks ago. We had to go totally virtual for a while. In fact, had to shut the hospital down for a week or so. But are now pretty much up and running, although we still do a lot of our teaching virtually, and particularly our lecture teaching and some of our laboratory teaching. We are back to fully functional hospital operations, and absolutely are out there treating your patients or your animals, the animals that you own for their cancer if they've got it, or for other conditions they might have. So tonight, I've got two speakers. Again, next slide. We are probably going to start off with David Vale. I think, oh, Lisa is on. So Lisa's going to be the first to go, as we expected. So Lisa Forrest is a professor of radiation oncology and diagnostic imaging. She's our radiation oncology section chief, and she's going to present her presentation will be titled Successful Clinical Trials in Pet Dogs and Nasal Tumors at UW Veterinary Care, led to the widespread use of tomotherapy in human medicine. Tonight, she'll share how a new radiation therapy delivery system is helping our patients. And following Lisa will be David Vale, professor in the Barbara A. Saran Chair in Comparative Oncology and the Medical Oncology section chief. And David's going to give an overview of his work and a broader look at comparative oncology research. So the plan is they will each give a presentation of about 15 minutes long, and then we'll reserve the questions for the end. And the three of us will basically come back on into this format and then I'll pose your questions that you present in the chat. So look at the chat box, and if you have any questions, please pose them there, and then I'll ask either David or Lisa to answer your questions. So with that, thank you for coming to our event. I hope you have a fantastic time and learn a lot. And Lisa, you're up.
Thank you very much, Dean Markell. I'm really excited to be here. Next slide, great. So I'm really excited to tell you about our new Radexact radiotherapy delivery system. It was installed this last fall, and we began treating radiation therapy students with this new technology the week of October 12th. Next slide, please. So the Radexact is the latest platform which builds on the original helical tomotherapy system, which is a combined linear accelerator and helical CT scanner. You can see this is our unit in our vault, and it looks just like a CT scanner, but it does have a linear accelerator that we can use to treat patients. The new system has increased versatility and accuracy, and we're using it to treat small animal, companion animal pets with cancer. Next slide, please. So the Accuray helical delivery started with Tomotherapy, which is a unique radiation delivery system. It was the first helical imaging and delivery platform that combines low-dose integrated daily CT imaging with continuous 360-degree radiation treatment delivery. It provides accurate patient positioning before each treatment, which leads to precise treatment of tumors and avoidance of critical structures. So what's important is this continuous helical delivery that is only provided by the Tomotherapy unit and now the second generation, the Radexact. And that is where that as the linear accelerator completes multiple 360-degree rotations, the patient is on the couch and is passing through the center of the bore of the machine. Next slide, please. So, what are these advancements and improvements? Well, I'm going to concentrate on three and talk to about each one individually. The first is improvement to the integrated daily imaging. The second is treatment adaptation software. And the third that's really great and new is Synchrony, which is real-time tumor motion tracking. So you can see in the slide to the right, we're setting up a patient into an immobilization device with an individual bite block made from dental material. Next slide, please. So starting with the integrated daily imaging. As you may recall, there's image-guided radiation therapy, IGRT, where with either the new system or the Tomotherapy, we would get a daily CT using the linear accelerator before we treat. This will be aligned with the planning CT prior to each treatment, which allows for precise treatment of tumors, precise avoidance of normal tissues with sub-millimeter accuracy. The advances with the new Radexact is that there's increased acquisition speed of these daily CTs, so that helps with the workflow. There's improved image resolution, and additionally, they're going to roll out a KVCT that's going to be adjacent to the linear accelerator for the image-guided RT, which will further improve image resolution. Next slide, please. So here we have a typical integrated daily image that we get with the Radexact. And what we have here on the panel on your left, we have a transverse or axial view of a skull, the nasal cavity actually, and a surrounding lip of a dog. The tumor is on the right side of the dog's lip, and on the panels next to that are the dorsal view or coronal view and the sagittal view. So you can see that there's a checkerboard color here. Well, the aqua represents the daily CT that we obtained, and then it's been aligned with the checkered areas, which are gray, which is the original planning CT. And then on the far right in that blue panel, we have the different positional translations that are in millimeters. And so we have a very small 2.3 millimeter lateral shift, no longitudinal shift, and a very small 0.3 millimeter vertical shift. And then on the line below, we have a small rotation of roll of 0.2 degrees. Next slide, please. So the next thing I wanted to concentrate on is the treatment plan adaptation. The Radexact features a precise art adaptive software. It's fully integrated and automated dose monitoring of the tumor and normal tissues. And this occurs during the entire process. So this happens every day. And if you look at the picture on the right, this is a transverse view of a CT of a dog where we've outlined the tumor of the lip with the white arrow. And then just above that is the eye, which is shaded in green with a green arrow. So over the treatment course, tumors can shrink, and this can result in overtreatment of normal tissue and undertreatment of the tumor. So if the tumor shrank, then it will affect the dose that the eye is getting. Well, this software will be able to tell you when it's at a point that you need to make a decision of whether or not you're going to change your treatment plan. And so this allows us to quickly adapt our plans, which will ensure optimal tumor treatment, as well as precise avoidance of the eye or other critical structures. Next slide, please. And then finally, I'm going to talk about Synchrony, which is real-time tumor motion tracking. And this is only available on the Radexact system. This is a dose delivery that is continuously synchronized to the tumor position during treatment. The treatment beam synchronizes to the tumor at all times during the treatment. And this is important for moving targets adjacent to the diaphragm, such as lung tumors or rib tumors, or tumors in the abdomen and the liver, gastrointestinal tract, etc. So if you look at the image on your left, this is a radiograph of a dog with a lung tumor that's outlined by the white arrow, and it is adjacent to the heart. And so we know that while the animal breathes during treatment, the heart is going to be beating, the lungs are going to be moving, and so this tumor is going to be moving. Now, the Synchrony allows superior avoidance of adjacent normal tissues and accuracy of tumor dose delivery. And all this is with continuous, uninterrupted treatment with tight treatment margins and tight dose gradients. So this will allow us to treat tumors that we probably couldn't treat effectively before, and with very more accurately. Next slide, please. So this is a cartoon that gives you a feeling of how the Synchrony real-time motion works. So on the right panel is what is happening with the Accuray motion Synchrony. And think of the faucet as the treatment machine, the water as the dose, and the glass as the tumor. So you can see that the machine, the Accuray machine, follows the tumor and creates a consistent treatment of the tumor and no treatment of surrounding tissues. Where on the other side, where in the left panel, in this case, you've made a wider beam so that you're always encompassing the tumor, but you're treating a large amount of normal tissue. Next slide, please. So the Radexact, this treatment modality is only available for veterinary patients at UW-Madison School of Veterinary Medicine. It's not at any other veterinary institution. The new system has faster image-guided radiotherapy with better image resolution, which gives precise treatments, and it has the improved adaptive treatment planning software that monitors the dose during the treatment every day to the tumor and normal tissue. And then finally, the exciting part is Synchrony, where we can have real-time tumor motion tracking. And all of this is increasing our precision and accuracy of treating tumors and avoiding normal tissues. Next slide, please. So in summary, we started with about 20 years ago, the original Tomotherapy unit, which was invented at UW-Madison. And we were lucky to be part of a program project grant where the first patients treated on the original machine were pet dogs with nasal tumors. And we documented the ability to create excellent treatment plans and deliver the dose. We then were able to show the image-guided capabilities, and we were able to treat the nasal tumors without and being able to spare the adjacent eyes. So this is important clinical trials, advancing treatments for our pet populations, and also providing information that will translate into treatments for human patients with cancers. And with that, thank you very much. And I'd like to hand it over to Dr. Vale, who will tell us all about our clinical trials at UW. Thank you.
Thanks, Lisa. That was really great. So as Lisa mentioned, I'm going to be talking about this concept of comparative oncology. It kind of falls under the umbrella of this notion of one health or one medicine. That is that, as is stated in the illustration here, perhaps the answer to treating cancer and curing cancer may be walking right beside us. And that is that our companions, our pet dogs and cats, have the almost identical incidence of cancer as we do in people. They often develop the same types of cancer as we do. And in particular, dogs tend to develop the kinds of cancer that pediatric patients, children, develop. So that's very important as well. And you know how we talk about 1 dog year equals 7 human years? The same really holds true chronologically for their cancers. Their cancers tend to develop and progress on a faster scale. So we can investigate by including our companions in clinical trials for novel cancer agents. We can determine whether a drug is helpful or hurtful in a much quicker period of time. So I'm going to introduce this idea of comparative oncology, and then I'm going to present 3 examples of clinical trials that we currently have ongoing here at the University of Wisconsin. We actually have over 24 trials ongoing currently. But these will help illustrate the association between our veterinary school and the Carbone Cancer Center, the Human Cancer Center here on campus, where we work together to develop novel cancer diagnostics, novel cancer therapeutics. So just the kind of the definition of comparative oncology, really germane to this discussion, is that we are including our companions, our pet dogs and cats, as a complementary patient population investigating novel cancer therapies. And the idea initially was that we will be informing the design of human trials of these anti-cancer agents and inform them in parallel, running clinical trials both in our companion species and in people. The key, of course, is that I'm a veterinarian at the end of the day, and I want any technology, any new drugs that are developed to come back into my veterinary clinic. And that's really the important part from a standpoint of bidirectional flow of information. So that's really key. And as Lisa illustrated, the classic example of that bidirectional flow here at University of Wisconsin is the development of the new Radexact and Accuray system. 20 years ago, Lisa and the veterinary group here got together with Rock Mackey, who's a medical physicist who was the inventor of tomotherapy, the idea of marrying a CT scanner with a radiation therapy unit. And we got together, and the very first patients treated were pet dogs with nasal cancer. And that led to our university having access, the only veterinary hospital in the world that has access to the Radexact Accuray technology. That's flowed back into our practice and helping our companion animals that present to our clinic. So what is the problem with developing new drugs? Well, it takes a tremendous amount of time and a tremendous amount of expense. As illustrated down on the left lower panel here, there are literally thousands of new drugs coming into the cancer pipeline. Coming into the cancer pipeline, but it's about an 8-year process on average to wean out down to a single approvable drug at a cost of about $1.5 billion per drug. And we got to do better than that. We got to compress that time. We got to make it less expensive to develop these drugs. And to illustrate that, Keytruda, which is one of the new immunotherapy drugs used for cancer in people, you see it advertised every night on the national news. This drug costs $13,000 a month per patient. And part of that reflects this $1.5 billion drug development cost. So the idea of comparative oncology is let's look across species, let's accelerate this process and make it more cost effective. Hopefully we can get newer drugs into the system quicker and at lower cost. So what are the opportunities available to us by including companion species in anti-cancer drug development? Well, there's a lot of, I'll just highlight a few of them, but the same problems occur in our pet dogs and cats as occur in people. The big problem is recurrence of cancer and spread or metastasis of cancer. Now, our companion animals, they share our environment, so they're exposed to similar toxins, similar carcinogenic agents. But importantly, unlike rodent models or most models of cancer research, dogs and cats have an intact immune system, and that's really important, especially in the context of today, immunotherapy being the area of cancer therapy that holds the most promise. Now, our pet dogs and cats are also of similar size to us, so we don't have to reinvent radiation therapy machines and imaging machines. We can use the same technology for both people and our companion species. The genetics of dog and cat cancer and the genetics of them as individuals is much closer to people than our rodent models. And the targets, the anti-cancer targets, have been shown over and over again to be very similar. So there are tremendous advantages. And I already mentioned the temporal advantage of cancers tend to develop and progress faster in dogs and cats, so that we can find out whether a drug is working or not working in a faster way and hopefully accelerate new therapies in a quicker process. Now, client enthusiasm for our investigational clinical trials is actually tremendous. We have people calling from all over the country, even outside of the country, trying to get into our clinical trials, especially for the very devastating forms of cancer that we deal with, such as hemangiosarcoma, cancer of blood vessels, non-Hodgkin's lymphoma, malignant melanoma, all cancers that occur in people as well, and are quite devastating. So these clinical trials are funded, so the actual cost of therapy and follow-up is generally paid for, and we're pushing the envelope with the therapies that we currently have available. So the current infrastructure, and we've been our group here has been a real leader in this idea of comparative oncology. We're a member of the Comparative Oncology Trials Consortium, which is a group of 20 veterinary schools that are affiliated with the National Cancer Institute, testing novel agents in our companion species for treating cancer. We're part of the Cancer Moonshot that was started by President Biden when he was vice president, pumping in a tremendous amount of dollars into cancer research. And we're one of only 6 veterinary schools in the world in this Comparative Oncology Research Consortium, which is a program that's run by the V Foundation that pairs comprehensive cancer centers like the Carbone Cancer Center, human cancer centers, with a veterinary school on the same campus to investigate novel agents. And I already mentioned that our pet dogs tend to get cancers very similar to kids, and so there's a lot of interest through pediatric cancer groups to fund this type of research. So let's talk about 3 clinical trials ongoing here. I'm going to spend the time talking about immunotherapy, which is really one of 5 treatment modalities for cancer, and it's the one that's showing the most promise. And essentially what we're trying to do is that the immune system, your immune system, my immune system, it was designed to circulate cells throughout our body to find cancer cells before they actually form into measurable cancers and kill them. As we get older, the immune system starts to break down, just like our joints, and it becomes weaker at distinguishing what is cancer and what is normal. And immunotherapy really is designed to re-energize our immune systems such that it does the job it was set out to do. And I just a shout out to my mentor, who was the very first veterinary medical oncologist to run immunotherapy trials in here at the University of Wisconsin, Greg McEwen. So the first study I'm going to talk about is funded by the Veterans Administration, and you'd wonder, why would the Veterans Administration be concerned with comparative oncology? Well, one of the common cancers that dogs get is a cancer called malignant melanoma, and it's a very devastating cancer in both people and in dogs. In people, it's sunlight driven. That is, that if you get a lot of sunlight exposure, you increase your cancer rates. And of course, our veterans serving in the Middle East, they have higher levels of sunlight exposure, and therefore they have higher levels of malignant melanoma than the general population. So that's why they're interested in this. And we teamed up with 2 members of the Carbone Cancer Center, Paul Sondel, a world-renowned pediatric oncologist and immunologist, and Mark Albertini, who heads up the melanoma grouping at the Human Cancer Center. And we're looking at ways of turning a patient's own tumor while it's still in the patient into a vaccine to stimulate the immune system. And this is actually the first patient of ours at the veterinary school to receive this new immunotherapy. This is Dino. He's currently under anesthesia and being passed through a imaging machine called a PET CT scanner. But Dino had a cancer of his shoulder, and shown on the PET CT scan here, this is a sagittal or kind of a slice image of his tumor. And this machine is lighting up anything that lights up bright, as is shown in this box, is his tumor. And it shows where there is light, that implies that the cells are rapidly dividing. And that's essentially what cancers are, rapidly dividing cells. Now, this is at baseline. And on the right panel, this is 1 week after injecting his tumor with the immunotherapy that creates a vaccine out of his own cancer. And you can see 1 week later, his tumor is no longer bright. It's actually absolutely cold, implying that the tumor is no longer dividing. So this trial is ongoing. We're including new patients with malignant melanoma. A similar trial and kind of an offshoot, this is funded by the Cancer Moonshot and the National Cancer Institute. We're working with Zach Morris, who's a human radiation oncologist, and Jamie Weichert, who's a chemist at the Carbone Cancer Center. One of the problems with treating metastatic cancer, that is, in the illustration, the cartoon down here, you see a dog with a cancer in his mouth, but he also has spread to his lungs. If we're going to deliver radiation therapy to that tumor, we have to focus the beam, as in the Radexact machine that Lisa talked about, but we can't irradiate the entire body. That normal tissues just will not tolerate it. Now, Jamie has developed a compound, it's a chemical structure, that we can actually put radiation particles within this compound and inject it intravenously. And this compound is only taken up by cancer cells, not normal cells. And so essentially what we do is we inject this compound intravenously, and radiation dose goes only to the primary tumor and the metastatic tumor. And it's been shown that a low dose of radiation is an immunostimulant, so further creating this vaccine effect. And we're actively entering cases. This is the very first patient that received this new immunotherapy. This is Rex. Unfortunately had widespread metastatic bone cancer. These are sagittal sections on the left of his tumor at different parts of his body. This is through the lungs here. You can see the lungs and the heart in the middle. This is through his shoulder blades, showing a tumor here. And this is through his pelvis, showing he also has another metastatic lesion in his pelvis. We inject him with this radioactive compound, which lights up in the PET CT scanner. And immediately after injection, you can see it's in his heart being pumped to the body. But 24 hours later, you can see it starts to build up in his pulmonary metastatic disease, in his pelvic disease, and in his shoulder disease. So we are showing and documenting that we can actually deliver radiation therapy to his tumors specifically and not to his normal tissues. Finally, we're very proud of our involvement with the Vaccine Against Canine Cancer study. Many of you are aware of this. We've gotten a lot of press over this. This is the largest interventional clinical trial in the history of veterinary medicine. It involves 800 cases. A third of them are being seen here at the University of Wisconsin. Some of you may have seen, we made the front page of the Wisconsin State Journal last year. When we started this trial, this was the very first patient to receive the vaccine. Essentially, it's technology that was developed by Stephen Johnson. He's actually the first individual at the University of Wisconsin to get a dual PhD. He's now at University of Arizona, and he designed a technology to prevent cancer through a vaccine that is agnostic of cancer type. That is, that this vaccine has the potential to produce a vaccine effect against many kinds of cancer: melanoma, non-Hodgkin's lymphoma, bone cancer, hemangiosarcoma. And so we started this trial. It involves 800 dogs. We've here at the University of Wisconsin entered the first 250 dogs in that trial, and that trial is ongoing at this point. So all of this, of course, takes a tremendous amount of manpower, person power for that matter. And I'd like to shout out thanks to all of us at the veterinary school involved in this research. And that's the group of good-looking individuals over here, people at the medical school and the Carbone Cancer Center, people in medical physics, and all of our funding that's come from various sources, both private and national, governmental, like the National Cancer Institute. And of course, we want to thank our clientele who entrust us with the health of their companions. This actual cartoon was created by the National Cancer Institute. This was a trial that we had run with canine osteosarcoma, and the paw print is made with the names of all the individual dogs that entered into the clinical trial. And with that, I'm going to turn things back over to Mark.
Thanks, David. So now is our question and answer session. We've got about 20-ish minutes. I've got a few questions already in the chat, so I'm going to lead off. Why don't we start with you, David? Annette asked, what's happening with the Rapamycin study? I guess she had a greyhound.
Right. So the Rapamycin study, rapamycin is a really interesting drug. It's involved in the turnover of bone, the cell signaling program that tells bone to turn over or not. And rapamycin blocks that particular pathway. And there was evidence in early models of cancer to suggest that it would be helpful for treating bone cancer. That trial was completed. It included over 300 dogs nationally. It was funded by the National Cancer Institute, actually the Comparative Oncology program at the National Cancer Institute. And that, unfortunately, like many studies, was a negative study in that it was just submitted for publication in a journal called Clinical Cancer Research. And there was no difference between the standard of care, which was amputation and chemotherapy, versus the treatment group, which was amputation, chemotherapy, and rapamycin. But we learned a tremendous amount. The biospecimens and the biomarkers that were collected from our patients are helping us to be able to define cancer earlier. And we've now moved on. That's actually a 5-part study. Rapamycin was the very first drug in the 5 parts, and we're now on to the 3rd particular treatment for that grouping of studies. It's funded by the Morris Animal Foundation and the National Cancer Institute. So it's the first example of a foundation whose charter is animal health and a foundation whose charter is human health have come together to co-fund a comparative oncology trial. So thank you for that question.
Awesome. Lisa, Jerry asked, can the Radexact be used to treat lung metastases? I know David talked about this a little bit, but you want to talk about lung metastases and the Radexact?
Certainly. It depends on how many there are. If there's a few, we can do targeted therapy to each one. And so that's a possibility. We've also given whole lung radiation, which we're not, it's kind of still on the experimental front with animals, but it is something that we can try in more of a palliative approach to treating lung cancers. But if there's, say there's 4 or 5 nodules that we can see and identify, we can go ahead and treat those with the Radexact machine, and we can likely treat them at one time. So that's something that's pretty exciting that we can do, and look forward to doing that more now with our new machine. Thank you for that question.
Awesome. David, Susan, Jean, and I would think David McNeil would also ask the same question. What are the most promising discoveries for treating hemangiosarcoma?
Yeah, hemangiosarcoma is our toughest cancer, as you know. It's an extremely aggressive cancer that metastasizes very quickly. So there's a very narrow window of opportunity to be able to act on that. And so, some of the most exciting areas of advancement are early detection. And this is detection before you could image to find the actual tumor. And if you can find it earlier, it's much more actionable. The possibility that you could intervene and get a successful outcome are much higher. So part of that study, the Vaccine Against Canine Cancer study that I mentioned with Stephen Johnson's group, we've now, with the help of David McNeil, further funding, and a couple of other groups, funding groups, have come up with a new panel from a very small blood sample to detect early stage hemangiosarcoma. And the flip side of that is that because of the markers that we found in the blood where we can detect it early, we can also now start to create a vaccine against those early biomarkers that will hopefully translate into an immune response very early in hemangiosarcoma before it can form actual tumors. Now, this is all just conjecture at this point. We have the panel. We believe that we can diagnose the disease earlier. The vaccine part of that particular research will just be beginning, and it'll probably be 5 years before we know whether it's an effective therapy. But that's certainly one area of very active research.
Awesome, thank you. David, this one's for you again. Lisa, you're going to be next. Tim asks, what is the effect of neutering? I believe Tim has a 4-year-old golden retriever male, but I'd say, why don't you talk about both males and females as far as the effect of neutering on cancer?
Yeah, it's a very interesting question, and one that is still a little muddy. So epidemiological studies have revealed that for certain tumor types, neutering is preventive for cancer. Neutering in the sense of either neutering or spaying is protective against some cancers. For example, breast cancer, mammary cancer in dogs. You can pretty much liquidate it by spaying a dog before its first heat. But there are other tumor types like bone cancer, for example, where there's a measurable, it's a small, but it's a measurable increase in the likelihood of developing bone cancer in certain breeds, for example, the Rottweiler, if you neuter them early. The bottom line is, from a standpoint of epidemiology, the benefits of neutering because of other health issues still trump that small increase in risk of cancer. So we're still recommending neutering early because the overall lifespan is longer in the neutered animal than in the unneutered animal. More research is being performed in that area because it's a very interesting area.
Thanks, David. Lisa, with the Radexact, what is your perspective as far as kind of the cancers that are most readily treatable with it? And what do you think the future is as far as the likely new cancers that maybe we're not doing yet, we'll be able to treat with the Radexact system?
We have a great track record with tumors of the nasal cavity, nasal tumors, other oral tumors such as malignant melanoma, fibrosarcoma. We treat appendicular, so tumors of the limbs, including osteosarcoma, fibrosarcoma, other tumors as well. What we haven't done a lot of, and I'm looking forward to treating more, are tumors in the lung, tumors in the liver, gastrointestinal tract. So those types of tumors, or even adrenal tumors. We haven't treated very many adrenal tumors. So I think there's lots of tumors that we will be able to treat more accurately, as well as prostatic tumors, bladder tumors, renal tumors. So those tumors that we haven't really treated because we're so worried about the surrounding tissues and motion. And I think with the Synchrony, it's really going to open up a lot of tumors that we can treat.
Awesome. David, Janet asked basically two questions, but they're both related to the treatment for lymphoma. One is, are there any new developments as far as lymphoma treatment? And two is, the IV radiation treatment you presented, is that something that could be used for lymphoma?
Yeah, that's a great question. Yes. Yes to the, there's actually one of our coworkers from the Carbone Cancer Center, Rainier Hernandez, who is involved with that group, Zach Morris and Jamie Weichert. They've actually treated, one of our toughest cancers to treat is T-cell non-Hodgkin's lymphoma in the dog. It's uniformly fatal, very progressive. And they have used that compound, that NM600, loaded with a radionuclide, the little particle that delivers radiation, and given it to mice. Now, again, this is mice, so it needs that translational step where we move it into our clinics into dogs. They have cured mice and created immune memory in mice with T-cell lymphoma by injecting low doses of that targeted radiation therapy. We have treated one dog with T-cell lymphoma with the marker for that within the NM600 drug, and shown that we get tremendous take-up of the drug by the dog's lymph nodes, the cancerous lymph nodes. So that's kind of the first step, and the next step is to actually start treating dogs with that. The key is with the immune system, the advantages are that there are no sanctuary sites. The immune system can get everywhere in the body where the tumor is hiding out. And the second point is the memory. If the immune system gets turned on and turned on enough, it will create memory so that the next time it sees that cell, it'll kill it much quicker and much easier. And so that's what's been shown in mice, that the leap is always from mouse to man, from mouse to dog. And so that's really where this idea of comparative oncology comes into play. That's really fascinating. Another one you had asked, the first question was new developments in lymphoma therapy. There was a new drug just granted this week, FDA approval, that we were part of a group that did a national study on, a new targeted oral medication for treating lymphoma in dogs. It's a baby step. It's particularly effective against T-cell, which is great because that's our tough one. But it's not going to be a standalone therapy. It's going to be plugged in to many of these other therapies. So yeah, we're making steps as we move along, and that drug is also a similar drug on the human side, being brought up in parallel. So good question.
Can you address, David, just because Richard asked while you were talking, talk about feline lymphoma and how what you're talking about relates to cats?
Yeah, so feline lymphoma, and I feel really bad. Cats in the comparative oncology world are kind of orphaned in that there's much fewer dollars in clinical trials going into, and I'm a cat lover. As Mark can attest, I had to unfortunately adopt my cats out because I developed nighttime feline-induced asthma a few years ago. But I'm a cat lover, and the idea of this comparative approach in cats is not as well brought along as it is in dogs. But feline lymphoma, luckily, the most common form of feline lymphoma is a very indolent cancer with survivals in years rather than months. But there are some aggressive forms of lymphoma in the cat as well. The National Cancer Institute does fund comparative trials in cats for tumors that are similar to people. Head and neck squamous cell carcinoma in the cat is very similar to squamous cell carcinoma in people. And there are some trials ongoing for that. But in general, most of the comparative oncology research is going on in dogs right now. And that's a shame, and it's changing to a degree.
Lisa, can you talk, Isla asked whether, what the latest developments are, particularly with the Radexact system with osteosarcoma, and whether we still pursue amputation or whether we pursue radiation therapy for a tumor, let's say in the proximal radius of a large breed dog or whatever it might be.
Right. I still think the gold standard of care is amputation followed by chemotherapy. I think what we are still trying to look at is doing stereotactic, where we give 3 large treatments in 1 week to the tumor, and then also do chemotherapy. And I think with the Radexact, it's going to be more accurate and the delivery. But I think David would agree that the gold standard still is amputation with chemotherapy. Do you agree, David?
Yeah, I think that's certainly the case currently, and part of that is just availability of radiation therapy. I think that the data coming out now with very conformal radiation plus chemotherapy is looking very equivalent to amputation plus chemotherapy.
Yeah, so I think we just need more data, and I'm excited that we can provide that with the Radexact and as we move forward.
Now you can imagine with kids, of course, different than dogs. Dogs are quadrupeds, and So quadrupeds do great after an amputation. They've still got 3 legs. They can run, jump, climb, swim, do all the things that 4-legged dogs can do. But in kids who develop bone cancer and you've got 2 legs, the importance of saving both limbs is much higher from a quality of life standpoint. And so there's still a tremendous amount of active research in dogs with osteosarcoma with an eye to preserving limb function for kids.
David, can you talk a little about a person's name? It's Voodoo something, but asked a question: are there any proactive actions that pet owners can do to promote a normal immune system long-term to hopefully prevent cancer?
Yeah.
Beyond maybe your vaccine trial, but yes. Or maybe
staying young. I mean, that's the fountain of youth, right? So it's something called immunosenescence. As we age, our immune systems tire and get old, just as our joints get old, just as our hearts get old. And, it's a real area of active research. There's a whole aging institute at the National Institutes of Health looking at these issues. How do we keep an immune system young? Exercise, healthy diet, just trying to stay as healthy as possible right now. There is a very, very large aging study going on in veterinary medicine right now, run out of the University of Washington. And it's actually the drug that was already mentioned, rapamycin. Rapamycin appears to be a drug that potentially can delay aging of various systems in the body. And that's part of that study. It's only one part of it. But yeah, I wish I could tell you there's a fountain of youth out there. The best thing is to stay healthy. Your immune system definitely functions better when you're healthy and active, just as your brain. If you keep your brain active, you're going to delay memory loss, etc. That's really all I can suggest at this point. There are a lot of nutraceuticals out there that promote the fact that they maintain the immune system. The data is lagging well behind the marketability of those products right now.
So David, I'm assuming you're not going to tell people about you playing basketball and that's how you've tried to maintain your youthfulness despite multiple injuries.
My body, since COVID hit, I haven't played basketball in 11 months. My body has never felt better in the last 2 years.
Before I wrap it up, maybe in the next 2 minutes, David, if you can answer these 2 questions. One is, Polly asked, when will I'm assuming her dog is on the vaccine trial. When will we know whether her dog received the placebo or the real vaccine? And then I'd like you to wrap up with really talk about the relationship between what we're doing at UW School of Veterinary Medicine and either pediatric cancer or human cancer. You did talk about it a little bit, but maybe pull that together a little bit more.
Sure. So as far as the vaccine against canine cancer study, from an epidemiological standpoint, I don't know which vaccine a particular dog gets, whether it's the placebo or the actual vaccine. And it's not a placebo; it actually has the adjuvant in it. Epidemiologically, that's all locked in place until the last dog finishes the last of the 5 years. So we're talking quite a ways down the road before we'll know the actual codes. There are tripwires. Like any major trial, there's an independent group that every 6 months looks at the data, blinded. We're blinded to it, but they're not, as to who is vaccinated and who is not, to look at 2 things. One, is there a side effect of the vaccine? That wasn't seen in any of the preliminary work, but when we're talking about 800 dogs, we might see a side effect. And the other thing is there an early efficacy signal? That is, do we really need to do 800 dogs? If after 200 dogs, it's obvious that that cohort of dogs is getting less cancer than the other, then the trial could be stopped early. But yeah, there's no way of breaking the codes before that time. So it's going to be a while. From a standpoint of our standing in the development of therapies for people and kids, by including companion species. I mean, the examples are increasing every year as we look at novel agents that have been shown to have activity in our pet dogs and cats being applied to people. The classic example in my mind, and I bring up that slide that I showed of my mentor, Greg McEwen, he started 20 years ago, 25 years ago, investigating a novel immunotherapy in dogs with bone cancer that actually showed efficacy, showed activity, and was moved on into pediatric trials and was confirmed to have activity in kids and is now used in children. The Radexact Tomotherapy scenario with Lisa's group, another classic example of that we showed safety and efficacy of a novel radiation delivery system much faster than could have been done in people. And now we've got that drug back in our clinic, or that technology back in our clinic. Another example is a drug called Tenovia, which is a lymphoma drug available to dogs now. It's FDA approved. That was actually a human drug that we investigated about 15 years ago, funded by Gilead, the people that bring you all the anti-COVID drugs. They also have a cancer division. And they developed that drug. We were looking at it in dogs with an eye to moving on into people. But now that drug is commercially available for use in dogs. So it's a two-way street. And the infrastructure is growing every year. So I think we're getting there.
So we're running close on time. Unfortunately, there's a few questions still in the chat or comment section that we haven't gotten to, but hopefully we can get those to Lisa and David and get those answered for you in the next day or two. So I just want to say thank you for joining us. Thank you, David and Lisa, for your presentations. We wouldn't be where we are today. UW School of Veterinary Medicine wouldn't be where it is as far as cancer treatment, the understanding of cancers both in animals as well as the potential benefit that investigation can have with humans without your support. We've had donors since the beginning of the school, giving to the school to enhance the cancer treatments that we do. Certainly, we're incredibly appreciative of the visibility that WeatherTech and David McNeil provided to the whole profession, and certainly to the School of Veterinary Medicine last year during the Super Bowl, and are thankful for all of you, to David, WeatherTech, and each of you as friends of the school for all that you've done for us. So with that, I think we're at the end of the hour, and I just want to thank you very much for joining us, and I hope you had a fantastic time and learned something. Take care and have a good evening.